Immunology, transplant rejection. So first, it's broken down into hyperacute, acute, chronic, and graft versus host disease. I'm going to give you kind of a hard, fast rule in order to decide which one it is right off rip, okay? So let's begin. Hyperacute is going to be ischemic and fibrinoid necrosis. If you see ischemia and fibrinoid necrosis, that can give you your idea that it's hyperacute. All right. Another hard, fast rule would be a patient receives the transplant, and then almost immediately, the transplant or the organ becomes modeled. All right, and there's thrombosis that occurs automatically when they connect it. Okay, and that's known as hyperacute. It's within minutes. It's while they're still on the table during surgery. Okay, it causes widespread thrombosis of the graft vessels, and you're going to see ischemia and fibrinoid necrosis. That's high yield. Okay. Next is acute. Acute, what they want you to know is that it's dense interstitial lymphocytic infiltrates. If you see interstitial lymphocytic infiltrates, boom, your answer is going to be acute. Okay, so a patient that has interstitial infiltrates, dense interstitial infiltrates, okay, lymphocytic infiltrates, then you know you're dealing with acute hypersensitivity reaction. It's going to be host T cells against graft MHC antigens. Okay, so it's going to be host T cells against graft MHC antigens. All right, and it's going to be within weeks to months. Next is going to be chronic. Chronic, if you see interstitial fibrosis, that's going to be chronic transplant rejection. Okay, it's usually years, okay, months to years after the transplant. And once again, that interstitial fibrosis is going to help you get the answer. Lastly is graft versus host disease. Graft versus host is going to be graft T cells fighting against your host MHC antigens. So it's actually the opposite of acute, where you have host T cells against the graft MHC antigens. It's opposite. Graft versus host is going to be the graft T cells against the host MHC antigens, all right? You're usually going to present with a macular papular rash that is very highly associated with GVHD for transplant rejection. And it's usually going to be seen in transplants of bone marrow and liver disease or liver transplants, because that's where you could see majority of antigens presenting, right? It's going to be a type 4 hypersensitivity reaction, and don't forget the macular papular rash. All right, so overall, quickly, hyperacute ischemia and fibrinoid necrosis that occurs pretty much immediately while on the table. It's due to pre-existing recipient antibodies reacting to donor antigens, and it's going to cause widespread thrombosis of the graft vessels. Acute is going to be host T cells against graft MHC antigens, and it's going to be seen dense interstitial lymphocytic infiltrate. Chronic is going to have years after the transplant, and you're going to see interstitial fibrosis. And then lastly is GVHD with the macular papular rash and jaundice, usually after a bone marrow or liver transplant, where the graft T cells fight against the host MHC antigens. It's a type 4 hypersensitivity reaction. All right, everybody, that's all. Thank you for coming along. It's been one hell of a ride. I really appreciate you all. If you have any questions at all, please be sure to reach out.